Hi, my name is Ken and welcome to another AFM video aimed at COVID-19 preparedness. Today we will be chatting about when, why and how to screen and separate suspected COVID patients from non-COVID patients. It is important to state right off the bat that screening and streaming, which is separating patients into groups and cohorts, is currently still recommended for all volume of COVID-19 cases by the World Health Organization. I bring this up because there has been some controversy around what to do, if COVID cases became large in volume with community transmission being commonplace. This describes level 4 in the WHO community transmissions levels. And at this point, can be assumed that patients with respiratory symptoms are likely COVID positive, but patients who come in for something unrelated, like COVID trauma, could also be positive, COVID positive, and can pose a risk to staff and other patients. Some have argued that at that point, screening and streaming becomes less important and all patients are to be treated as possible COVID-19. There is no clear or easy answer to this, so follow local policy and regulation regarding screening and streaming. Okay, so what's the purpose of screening and streaming in the first place? Why should we go through the trouble of restructuring our patient flow in the emergency units and our health facilities? Firstly, separating suspected COVID patient from non-COVID patient helps stop the spread of the disease within your facility and community by minimizing patients to patient spread. Secondly, by having cohort of suspected COVID patients in one place, staff can take extra precaution to protect themselves when entering such an area. And thirdly, screening facilitates testing of COVID-19 disease and also streamlines processes specific to patients with COVID-19 disease. So that's the why. Now let's look at the how. So you will see on the screen a flow diagram depicting the screening and the streaming process. I will give you a few moments to have a look at it and to get a general idea before we go into the specifics. This flow diagram is available from the AFM resource page, which we'll link to at the end of the video. Planning. This is the most important and crucial step of all. For this process to work, it must be applicable to your setting and therefore must be planned with your context in mind. Now, first off, think through the process carefully and at each step envision what it will be like from the patient perspective. In order to do that, a process map of the patient journey is very useful. Detail this process map with the involvement of all stakeholders from hospital management, doctors and nurses, cleaning staff and clerical staff, ironing out as much wrinkles as possible in the planning stage means that it won't be too difficult to troubleshoot in the implementation phase. Try to keep the patient flow as unidirectional and as one-way as possible, and keep in mind that a suspected COVID patient may have to transit from one location to another within the hospital, and attempt to keep these COVID patient pathways from intersecting from non-COVID patient pathway as much as that is possible. So once that mapping and planning is done, do a physical walk through to see if there is any missing step. Checking that staffing levels are feasible to maintain the patient separation and flow, and you have to talk with the hospital management about staffing needs and reassignment if possible. Now let's move on to screening. Essentially, this is the step that will separate patients suspected of COVID-19 disease and those who are not into separate flow pathways in your emergency unit and facility. A good method to plan this is to think of each process in terms of what would be needed. Space refers to the actual physical space or area, its locations and its property. Staff encompasses both clinical and non-clinical staff necessary to accomplish process. When it comes to staff with you, it refers to the equipment needed, from medical equipment to something as simple as just stationery. And finally, a task are all the small sub-processes that will need to be accomplished in order to achieve the overall goal, in this case, screening. Okay, with that framework in mind, let's take a closer look at the screening process itself. So first, one has to identify the space needed for screening. This should be located outside the facility, close to the entrance of the hospital or the EU, with clear signage in local languages, should direct patients to come to the screening process, the screening station, before entering the facility. The space could be as simple as a desk and chair placed outside the entrance, or even a tent. Whatever it is, it should be well ventilated and ideally offer privacy and protection from the element. When it comes to the staff, it could be a junior clinician or a nursing assistant or a junior doctor. The staff could be trained to screen and have a written protocol to work from, including a mechanism to alert a senior clinician in case of uncertainty. So this helps to rosters, and such as screening occurs 24/7. Otherwise, it wouldn't be efficient if it's just temporarily done. And the roster should factor in breaks and off times as for staff wellness. When it comes to staff, meaning the things that are needed, a desk, chair, and PPE for staff, hand sanitizer, or a facility for hand hygiene with soap and clean water. So that's one of the few things that we need to have. An electronic or hard copy of the protocol for screening, mask for patients, and including an updated case definition. When it comes to the task, the staff member should question the person being screened against the updated case definition. And if the case definition is met, he should give and demonstrate how to apply a face mask to the patient. The staff member should direct the screen positive patient to the COVID triage area of the emergency unit, and the screen negative person to the non-COVID EU triage area. So clear signage should also direct the patient to this respective area.
Good morning, sir.
Good morning.
How are you?
I'm not that great today.
Okay, sir. My name is Dr. Zinanyani, and your name is?
My name is Ken.
Ken.
Yes.
Okay. And your surname?
My surname is Diango.
Diango. Mr. Ken Diango. Okay, sir. Do you have any fever?
No, I'm not really that fever.
Okay. Are you coughing?
Yes, I've been coughing for the past 2 days.
Okay. Are you feeling short of breath?
Yes, from time to time I'm struggling to breathe.
Okay. Any sore throat?
Not really, I don't think really that much.
Okay. Thank you very much, Mr. Diango. You may proceed behind that line, please.
Thank you.
Thank you.
So the next thing to consider is the COVID emergency unit area itself. So it is a space that will house many processes, and such as triage, treatment, and resuscitation, similar to the non-COVID or normal emergency unit area. So the COVID emergency unit area should be physically distinct and separate from the normal EU. One has to delineate separate areas for triage, treatment, resuscitation, and a waiting room. These areas should be well ventilated, ideally with no air circulating to the non-COVID areas of the hospital. However, and as a last resort, emergency units should have clear demarcation with, at the minimum, a soft barrier, such as curtains separating it from the main emergency unit area. Don't forget non-clinical areas such as bathroom, writing station for staff, and you need to go through the space, staff and task planning method for each of these sub areas. For the purpose of this video, we will not go through each step for each area. except to highlight a few important points. So the staff in the COVID emergency unit area must be trained in and provided with PPE. You need to take into account non-clinical staff such as kitchen staff, security personnel, cleaning staff, as far as possible to minimize contact between non-clinical and staff patients. This area, which is the COVID emergency area, need to function 24/7, and staff will need to be rostered to provide continuous care. So that's just another details about the staff COVID in the emergency unit area. Without going into much details, the COVID emergency unit need to be equipped with a focus on respiratory illnesses. For example, stock a large proportion of oxygen delivery devices. There are many processes and tasks that will occur within the COVID emergency unit space. Each one could be on its own video. For the sake of brevity, only few points will be highlighted. So let's talk about triage, for example. The triage should occur separate from normal non-COVID triage area, in a designated space closed to and within the COVID emergency unit entrance. It can be as simple as a table and a chair with triaging equipment, but should ideally offer some privacy. Dedicated triaging staff and equipment is ideal, with a no-touch thermometer if possible. Let's talk about registration. As previously mentioned, minimize contact with clerk registering patients and minimize the transfer of patient folder out of the unit as they may be contaminated. Tests, labs and imaging where possible. Perform bedside tests and try to limit patient movement out of the unit for testing purposes. For example, rather use a portable X-ray than send the patient to the X-ray department. It is important to note that swabbing for COVID is considered an aerosol generating procedure, also called AJP, and should occur with full PPE including N95 mask in a well-ventilated area, ideally a negative pressure room. Treatment with regard to resuscitation. Many countries and national society have taken a firm stance regarding CPR during the pandemic, and this local guideline must be adhered to. But keep in mind the risk CPR pose in terms of staff exposure and take steps to keep staff protected. Minimize AJPs, aerosol generating procedures, we said. For example, MDI plus pacer use is preferred over nebulization. Intubation is also an AJP, so full PPE is required. And finally, we arrive at the end of the process map, disposition. So patients are either sent home to self-isolate according to the local protocol or admitted to the ward or the ICU. Patient may also need to be referred to a high level of care, but in these places, EMS crews and the referral hospital can be at risk. This should be done according to a pre-arranged local protocol that minimizes transfers and referral. Well, I hope this has helped you understand how to separate and stream suspected COVID positive patient from non-COVID patient. Remember to physically walk through these patient pathways to identify and correct any gaps. So let's go over what we've learned. So we've learned the importance of screening, and it's recommended for all volume of COVID-19 cases. We have learned how to screen and separate patient pathways using the space, staff, and task method to plan. Thanks again for watching this FM video. Tune in next time for more great resources. Bye.